First of all, I'd like to thank Professor Dr. Ali Abbasi and Dr. Sweedan for giving me this opportunity to share the case with this young lady. She's actually 37 years old, female patient. She complained of progressive weight gain, enlargement of both hands and feet, and change in her facial features over several months. On seeing this patient, she had coarse facial features, she had frontal pulsing, she has large nose and large hands and feet. Her abdominal and neck examination, chest examination were all unremarkable. Given these signs and symptoms, we were thinking about acromegaly. So we have to confirm this biochemically. We did the lab test, her glycemic control, her blood sugar was normal, serum prolactin, thyroid function tests were all normal. For growth hormone, the basal hormone and after oral glucose tolerance test revealed that there is no suppression of growth hormone, unsuppressed level, and the IGF-1 was high. In order to continue our investigations, we did an MRI which revealed that there is 1.4 by 1 by 2 pituitary adenoma or hyperplasia. So what to do next? Should we go for transphenodal surgery, gamma knife irradiation, or medical treatment in the form of cabergoline or sandostatin?
Well, this is surely a kind of straightforward case, now that we have a clinical picture, we confirm this biochemically, and that this acromegaly, we've seen the imaging, and it confirms pituitary lesion. So, our first line treatment in such a case is surgery, and it's usually transplant surgery if possible. So, indeed, we sent this patient to a neurosurgeon looking for transplant surgery, and this lady was assessed for surgery that misses muscular chest X-ray. Remember that we didn't find anything on examining her, and the chest X-ray showed a mass, and a CT chest was done obviously because of the chest lesion, and it confirmed that there is a 7.5 centimeter mass. So, at this stage, we have two options. Either we go for transplant surgery, or should we go for the chest lesion first? And it's open discussion. What would everybody do? Would anybody do?
Okay, actually, yes, we saw that it's the two of them.
Right.
Okay. We saw that there is no urgency for going to transphenodal surgery. We wanted to know a little bit more about this chest lesion. Actually, she was referred to a cardiosurgeon and other investigations were done, but at the end, a right lower lobectomy was done. Then a follow-up CT after the surgery revealed that the mass was totally removed. To our surprise, we were actually surprised that the pathology report came that it's a lung carcinoid, well-differentiated neuroendocrine carcinoma, which is no distant metastasis or angiolymphatic invasion. For confirmation, sanatophysine and chromogranin A staining was done, which came back positive. Okay, back to the pituitary. Actually, the patient felt that she's getting better at that time after the surgery. What shall we do next? Shall we go for transphenodal surgery again? Shall we wait and see, or shall we repeat the blood test?
Again, for anybody to maybe tell us what they think. What do we do at this situation? Should we go for surgery? Should we wait and see, or should we repeat any blood test? Okay. Thank you very much, Mr. Okay, right, okay. I think we have the opinion of repeating the blood test. I think there are two things here. As Professor Nabil has already told us, pathology is very important. So we have to consider that with caution. The other thing is we have to listen to the patient. The patient feels better. She thinks she's getting better. So why don't we go with what the patient says? I know it's not always true with all patients, but if the patient is a reasonable person, we should listen to them. We should listen to our patients. These are the things that we learn from our patients. as Professor Samir learned from him that we should listen to the patient, as well as all my professor. And we've done the blood tests to check for her growth hormone and the IGF-1, and indeed they were suppressed. So the growth hormone, after the oral glucose test was suppressed, the IGF-1 was normalized. We've done the other blood tests, as we've done before, like the thyroid functions, and they were all normal. They were all back to normal. So we had an oncologist involved with us, and we thought we'd do a PET scan just to make sure that we're not missing anything. And indeed, again, PET scan was negative. There wasn't anything. There wasn't any metastasis, as we expected from completely moving off the chest lesion. But how do we link? We have another PV link, Professor Abdel. How do we link between acromegaly and this lung lesion?
As we all know that most of the cases of acromegaly, about 95% of the cases of acromegaly are caused by benign pituitary adenomas. Less than 1% is caused by non-pituitary tumors, and the most common of them are carcinoids, which are commonly occurring in GIT, and the second most common site will be the lungs. Single cases have been reported to occur due to tumors in the duodenum, in the liver, and in the pancreas. What about the pulmonary neuroendocrine tumors? They are actually very rare tumors. With an incidence of 0.2 to 2 in 100,000 in the United States. They are about 25% of all neuroendocrine neoplasias and about 2% of the lung tumors. They can be classified into typical carcinoids, atypical carcinoids, large cell neuroendocrine carcinomas, and small cell lung cancer, which is considered a single entity as itself. Typical carcinoids are more common than atypical carcinoids. Neuroendocrine tumors of the lungs have been associated with paraneoplastic syndromes, including carcinoids, Cushing syndrome, and syndrome of inappropriate antidiuretic hormone, and very rarely acromegaly. So, to sum up,
we do have here a case of acromegaly caused by a neuroendocrine tumor in the lung, which was completely resolved by just removing the neuroendocrine tumor. I just want to say that me and Professor Abdel did not prepare anything of this, it just came by coincidence. We are happy to have any questions.